Hi, everyone. I'm Maria Monroe-DeVita, and welcome to our February MHTTC National ACT virtual meetup. Just a couple of things that we're going to cover here before we get started today. Here is our agenda. We're going to do some brief introductions and just a quick announcement. We kind of keep putting in this plug that we have the online, 2-hour online free training that Lorna and I put together on the ACT e-primer. It's an orientation to ACT. So we'll put that link in the chat. Today, we're excited to have a special topic from Dr. Sarah Kopelovich, who is right down the hall from me, although today I'm homesick, so we're not down the hall from each other today. She will be talking about Psychosis REACH, which is a CBT-informed care approach for families and caregivers. And then we'll continue on our open mic, where we ask you all to kind of post questions, share resources, that kind of thing. And then we'll meet again in 2 months. So every other month we meet on Monday, April 3rd. And just so you all know, Dr. Pat Deegan just confirmed that she will be presenting at that one to talk about the role of peers in medication management and discussing medications, as we know that's a big topic for our ACT teams. Quick housekeeping, as many of you know, you're muted and your video is off during the call. We are recording it. We'll post that recording. You'll get information to be able to access it in the future. The slides are also on the website, and I'll put that in the chat as well so that you can access that during this call. Just a couple quick things. So if you have just a comment to make, feel free to use the chat, but if you have a question, go to the Q&A box. And that way, that helps us to track the questions, to make sure we've answered all the questions, whether it's live on this webinar, or we'll often put a response into the Q&A box to answer the question if we don't have time for it live. But that helps us kind of keep track of that. So please do use that Q&A box. And I introduced myself just a moment ago, but I am affiliated with the Northwest MHTTC and the Spirit Lab at University of Washington in the Department of Psychiatry, and lead training of our ACT teams here in Washington State, as well as with many of your organizations nationally. And I'm the co-author of the Team ACT Fidelity Tool. And I'll turn it over to Lorna for her introduction.
Hi, everyone. So happy to be back with you all, and pretty much everything that Maria said, except I'm at UNC in Chapel Hill and am the director of the Institute for Best Practices here. Yeah, so we are excited to have Sarah with us, and that's about it.
Okay, excellent. So Sarah, I'm going to just do a quick shout out and introducing you. So Dr. Sarah Kopelovich is a licensed clinical psychologist in the Department of Psychiatry and Behavioral Sciences at the University of Washington School of Medicine. She is an associate professor in the department and holds the professorship in cognitive behavioral therapy for psychosis. She directs the Northwest CBT for Psychosis Provider Network, serves on the steering committee of the North American CBTP Network, and is a co-founder of the Center for Mental Health Policy and the Law at the University of Washington. She is a co-developer of the Psychosis REACH model, which she'll be sharing with all of us today. I'll turn it over to you, Sarah.
Thank you so much. I'm so happy to be here, and I'm in such admiration of the just devotion of everybody, 167 and counting folks on this call from all over the country. Really, really just such an impressive display of commitment to serving this population and to coordinating with your colleagues across the country. So I'm really delighted to talk about Psychosis REACH. REACH stands for Recovery by Enabling Adult Carers at Home. This intervention has really been a grassroots intervention that started about 4 years ago. The impetus for this training program was actually a family member here in Washington State who said, I just returned from hearing Dr. Douglas Turkington, the developer of CBT for psychosis, speak at the National Alliance on Mental Illness Convention. And he said that you can teach family members cognitive behavioral techniques for psychosis. And I said, yeah, well, that's true. And it really hasn't been done before. And she said, you have to bring it to Washington. We have to do this. And from there, it's grown to really being a national effort with a growing evidence base surrounding it. So I'm very, very pleased to be talking to you about it today. I really want to give a big shout out to my colleagues. Maria Monroe-DeVita has been influential in the genesis of Psychosis REACH. And in addition to Douglas Turkington, who's in the center with Kate Hardy, my colleague at Stanford University, my colleagues here at University of Washington, Dr. Akadra Baswani Bai in the upper right-hand corner, Victoria Shepard, who's our lead project coordinator, Trez Buckland in the lower right-hand corner, who is now our family ambassador of Psychosis REACH, and I'll talk more about that role in a moment, but she's officially joined our training team. She's also a parent with lived experience with schizophrenia, and our incredible family members who have really informed this intervention. So during the time I have with you today, I primarily want to convey that family education, support, and therapeutic skills training is not a peripheral objective of ACT. It is a focal service domain and an indicator of ACT fidelity. So my primary objective is to share the empirical rationale for a family intervention for psychosis, which is what Psychosis REACH is. And at the same time, there are a lot of reasons why clinical teams struggle to administer family interventions. So my secondary objective is to illustrate how Psychosis REACH is really designed to address the access gaps that we have in this area. And then I'll summarize the Psychosis REACH model, both what it is and how we train family members. And then finally, I'll share with you the options for bringing Psychosis REACH to your region. And I'll also, you can also learn more about Psychosis REACH and access resources at the website, which is the URL is just right here on this slide. I do want to make a quick note on terminology. So I'll be using the terms family and natural supports interchangeably. Of course, we recognize that ACT clients, by the time folks get to ACT, are often quite isolated. They may have already become estranged from family and close friends. So I'll be using the terms family and natural supports to refer to anyone that the client has in their life who's a source of pro-social support, whether that's a roommate, another ACT peer, or a relative. So as Maria mentioned, she and I are colleagues at the University of Washington Spirit Lab, as well as on the Northwest MHTTC. And one of our strategic objectives is that all clients that are navigating psychosis receive high quality psychoeducation and cognitive behavioral therapy for psychosis. I recently conducted and published a point prevalence estimate looking at CBT for psychosis training across the US and Canada. And according to that preliminary estimate, only 0.57% of clinicians in the US and Canada have been trained in CBT for psychosis. So 99 and change percent of Americans with a psychotic disorder do not get access to this intervention. And if you kind of work the numbers, we have 15 CBTP trained therapists for every 10,000 patients. Another objective of our lab is focused on families of those who are, supporting individuals with serious mental illness. And according to we know that we want to see all of them receiving psychoeducation and skills training because they are on the front lines of their loved one's mental illness. But according to a relatively recent 2017 report that was conducted by a committee commissioned by the federal government, 98.1% of Americans lack access to any family intervention for psychosis. And primarily what they were looking at was psychoeducation, which I sort of think of as the floor, right? You should know what your loved one's diagnosis is and what that means and what the indicated interventions are. And according to them, fewer than 2% of Americans were receiving that. And then, when we think about sort of as a whole, what kinds of care Americans with a primary psychotic disorder are receiving, by NIMH's estimates, at least 40% of Americans are not getting any care at all. And so we have to think about these rates when we think about the outcomes that are associated with schizophrenia, right? At this moment in history, we have more treatment options and more scientific evidence for those treatment options than has ever been the case in human history, specifically, of course, for schizophrenia spectrum disorders. And yet our outcomes, particularly in the United States, remain shameful, right? We have 28 and a half years early mortality, 50% lifetime prevalence of homelessness. I mean, you all are really familiar with these statistics and in a very tangible way. And I think for far too long, we've really blamed the severity of the disease without giving due fault to the care systems. And so if we are going to start to redress these access gaps and these quality gaps, it really does take a mental health service core that engages non-professionals as well as mental health professionals and allied professionals, right? We all need to be working together, and ideally we're all speaking the same language, that kind of working with the same theoretical framework, so we're not working at cross purposes. So what do I mean by that? If the family is working from a social spiritual framework, that psychosis is a mark of demonic possession, in which an exorcism is seen as the treatment of choice. And the individual with psychosis believes that he's being punished by God and there's no hope for recovery. And the care team is working from a biological framework in which biological interventions are seen as the most viable option for symptom control. Then everyone's working at cross purposes. Cognitive behavioral therapy, while not a panacea, advances a biopsychosocial spiritual framework in which the stress vulnerability model can really help us to understand how all of these pieces fit together, how the client's understanding might be keeping him stuck, right? How the family's understanding may, while very well intentioned, may be causing undue stress for the loved one. CBT can give us all a common language and a shared understanding that it's not any one factor, but a combination of factors. It can also give us, importantly, a set of tools, evidence-based tools, that each member of the support team can use to help the individual. And we have a large volume now of literature that demonstrates that cognitive behavioral therapy and cognitive behavioral techniques can be used by non-therapists. I'm sure there are many folks on this call who are using these techniques in the course of your work. And we also have seen that the use of CBT-informed care or coaching can amplify the work of CBT for psychosis. So if your ACT team is fortunate enough to have a provider who is trained in formulation-based cognitive behavioral therapy to fidelity, then the work that other members of the care team and the natural support team can do can really amplify that CBTP and really facilitate the learning process for our ACT clients that have a lot of learning impediments. So I really want to advance this thesis that when we engage family, everyone benefits. They really enable family caregivers to have a profoundly positive effect on their loved one's recovery. And that would just be a difficult point for me to overstate. We have literature that suggests that we see improved adherence or consistency with the treatment plan. We have reductions in relapse rates. We have fewer hospital admissions. And when the individual is admitted, shorter inpatient stays, better treatment outcomes in terms of the symptom severity, better work and role performance, overall improvement in quality of life. And that's usually one of the trickier outcomes in clinical trial research to achieve among this population for a number of reasons. Reduced substance use. And then this was this Riviere study from 2015 was actually looking at the 10-year longitudinal study of first episode psychosis service users. And that found that the risk of unnatural death in those whose family members were involved in their care was reduced by 90%. And then there was a systematic review that Maria and I were engaged in that was commissioned by the American Psychiatric Association that found that the effect sizes for family interventions for psychosis were comparable to medication. Now, in spite of this, we also know that most mental health providers report no contact with the families of the clients. And this is a complicated issue, right? This is not just for lack of trying. There's all sorts of reasons that play into this. Sometimes the clinic can serve, or the clinical team can serve as a bottleneck for getting these interventions. Sometimes family members are so overwhelmed that it's just difficult for them to make appointments. We have clinicians who are not trained in family interventions. But what we know is that the status quo is having harmful effects on caregivers as well, right? We have significant economic impacts of caregiving for a loved one with schizophrenia. We have emotional challenges, in particular, clinical levels of depression and clinical levels of burnout as well. And these are at rates that are equivalent to those that are reported by paid inpatient psychiatric staff. This is an article that literally just landed on February 1st of this year, right? So 5 days ago, really hot off the presses. And it looked at the symptomatology and relapse rates of individuals with serious mental illness, as well as caregiver health outcomes and burden over the course of the pandemic, up to 9 months out. And what they found, you can see highlighted in yellow, was that essentially psychopathology among this population seems to be getting worse over the course of the pandemic. And caregiver burden and health conditions also seem to be getting worse over the course of the pandemic. So the pandemic has really only worsened caregiver burden and health, as well as client clinical outcomes. So we have, really a lot of difficulty with getting family interventions for psychosis, as well as CBT for psychosis, to the intended beneficiaries. Nobody's benefiting. So how do we redress this issue? How does Psychosis REACH specifically redress this issue? Psychosis REACH takes the family intervention, which is informed by cognitive behavioral therapy, out of the clinic, and it brings it directly to the family members, right? So we actually leverage a training model that doesn't rely on the clinicians to deliver the intervention, and technology enables us to do that. This also allows natural supports and the care team to all be speaking cognitive behavioral therapy, right? We want everybody speaking the same language, and we want to start to reduce some of the burden on the care team, who, particularly because of the workforce crisis, are so overtaxed right now. And I'll talk a minute about how we do that, but first I want to just share some preliminary outcomes with you. When we did our initial research looking at the outcomes on the family members of undergoing just 8 hours of Psychosis REACH training, what we found were up to 4 months after that 8-hour training ended, reduced levels of burnout, reduced something called emotional expression, or the emotional tone in the home became calmer, less conflictual, less anxious, less hostile. We saw reductions in anxiety and depression among the caregivers. And we saw more of an adoption of a recovery orientation. Another way of saying this is that we actually saw less psychosis-related stigma. And then just qualitatively, when we asked, our family members, what was the value of Psychosis REACH to you? How did it, impact your family? Our family members started to share that when they started to use the skills we were teaching them, in combination with the shift in perspective, that their family members started opening up to them more. Their family members started to They started having less conflictual interactions, and their family members started to come through rather than just the symptoms coming through. And one mom said, I heard my sons laugh again. This mom also shared that her son, for the first time in over a decade, started calling her mom again. The other thing that we're seeing is advocacy on all levels. So when a lot of our family members actually aren't, because they're not even given that psychoeducation, they don't know what to expect in terms of the types of treatments that their loved ones should be getting as dictated by our national psychosis treatment guidelines. So they would say things like, I heard talk therapy doesn't work for psychosis, or my prescriber told me that, talking about delusions can make them worse, or CBT doesn't work for psychosis. And so when we arm them with accurate information, we can teach them to be advocates. And that could just mean advocates for their loved one. Why isn't my loved one getting offered CBT? Where can they get CBT? It could be in that care setting, whether that's a PAC team or the broader community behavioral health agency or their inpatient setting. And some of our family members have also started to advocate at the policy level, right? We actually in Washington State had a bill that went through our short session last year and came very close to getting passed that would have actually mandated Psychosis REACH training, as well as a Bureau of Family Engagement at all of our state hospitals. So that's the power of families when you educate them and empower them. All right, so let's just talk about what Psychosis REACH covers and then how we train our family members in this intervention. So Psychosis REACH has three core areas. The first is recovery-oriented psychoeducation. We really want to empower families by teaching them about their loved one's mental health condition and providing a culturally informed and evidence-based model for conceptualizing their disorder. This can help sort of start to address some of the stigma that we see, some of the hopelessness we see, and we're trying to ground their hope for recovery in empiricism. Even though I did kind of mention earlier, we have a lot of doom and gloom literature, empirical literature around psychosis, psychotic disorders. When we look at longitudinal data, we learn that psychosis arcs toward recovery. Oftentimes in mental health, on inpatient, on ACT, in forensic settings, we have a bit of a sampling bias because we're only seeing the folks that are most severely impacted by their psychotic illness. But we fail to see the folks that have a full recovery from an initial psychotic episode and don't have subsequent episodes, or learn how to manage their psychotic disorder and maintain their tenure in the community. So we really want to make sure that we're sort of correcting some misconceptions about psychosis and giving them hope. The second is caregiver self-care. And in caregiver self-care, we really emphasize the importance of managing their stress as caregivers. And that focus is based on two areas of psychological research. One is the relationship between stressful communication and a major a relapse of a major mental health episode. And that's a construct known as expressed emotion, which I referred to a few minutes ago, which really indicates that we can substantially reduce the risk of a psychotic relapse if we can help the caregiver to regulate their own emotions and to communicate with their loved one in that more regulated state, right? And then the second area of research is really that the same kinds of cognitive behavioral techniques that are indicated for mood and psychotic symptoms are also helpful to manage caregiver burnout, right? CBT is an indicated intervention for burnout. So we want them to start using those skills and other lifestyle changes to help them regulate their own emotions and also just model, right? It's not just about their loved one learning skills. Everybody needs these skills and benefits from them. And then finally, we are training family members in evidence-based cognitive behavioral techniques that they can execute without a lot of training, right? They don't need to get a graduate degree. I mentioned earlier, it was an 8-hour training. although we have found in subsequent research that family members really need some ongoing support to really get proficient in those skills, just like we do. The cognitive behavioral techniques that we teach family members go by the acronym FIRST. And the FIRST skills are really, it's an acronym, but it's also a mnemonic device that we are trying to help our family members to remember to default to these skills first before they fall back on old habits. And so I'm just going to quickly go over all of these, but of course, this is what our intensive training is really focused on. And the F in the FIRST skills is to fall back on your relationship. And this is based on psychotherapeutic evidence that suggests that the therapeutic relationship is key to positive outcomes in therapy, right? We really can't do anything helpful from a position of conflict. So we are working with family members to help them reset a relationship that may have gotten quite conflictual over several years, if not decades. And so that can take some time. And we really want to teach them that there is huge benefit if they can stay with the F skills until trust has been regained, rapport has been regained, and critically, that by the end of the F skills, they have really developed a shared goal with their loved one. And oftentimes they'll say, well, we don't see eye to eye on anything. I want them on their medications. They think that, intense meditation is the best therapeutic element for them. And so we'll teach them how they can actually develop that shared goal that they both agree on. The second is the I skills, or inquire curiously. Those of you who are familiar with CBT will recognize that inquiry, Socratic dialogue, those open-ended, non-judgmental, curious questions are really a hallmark of cognitive behavioral therapy. And so we teach family members to drop their own assumptions, to drop judgments, and to seek to understand their loved one's perspective through Socratic questioning, really fostering their sense of curiosity. Where do you think the voices come from? When did you first decide that that was the case? What other explanations have you heard? Have you ever, at any point, did you ever think that any of those explanations might be plausible? What do other people think about their voices? And you really need that foundation in the relationship in order to be able to ask those kinds of questions so that the person doesn't feel like you're challenging or threatening their perspective. You're merely seeking to understand them. The third is the R skills, and that's where we teach the families to review what they've learned through their gentle questioning and to put that information together to help them and their loved one get on the same page about how we make sense of that experience. What's the role of stress in their experiences or their symptoms? And to really orient to the role of their cognitions, right? That filter that we have between the situation and our feelings about the situation, and where that cognitive filter might have come from. The fourth skill is the S skills, and these are the cognitive behavioral techniques. So we're looking at cognitive skills, we're looking at behavioral skills, we're looking at problem solving skills. And so before, a lot of people think cognitive behavioral techniques, we're just going to teach them, breathing techniques, and we're going to teach them voice time, and we're going to teach them anxiety management strategies. Before we can try to work with the individual to develop new behaviors, new patterns, we need to first get on the same page with them with that shared goal, and they need to trust us, and they need to be willing to try new things. So you could see how we are laying the groundwork, and you'll all have access to a handout where we have a pyramid of the F skills to really make sure that people know those F skills are the foundation, and we're working towards these higher level skills. And so it's not until our fifth and final skills, the T skills, that we're really having them try out different cognitive behavioral and problem solving skills and give us feedback. So what I want to do now is share a quick 5-minute video of our Psychosis REACH family ambassador, Trez Buckland, who's going to be talking about a concrete example where she used the first skill with her son. And please let me know if you can't hear. Maria, I'm looking at you. Can you hear that?
No.
Okay, no problem. Let me just, oops.
Oh, I'll bet, yeah, you have to enable it probably.
All right, let's try that one more time.
Schizophrenia when he was 16. And my husband and I have
All good now?
had a wonderful journey with him over these years. It's had its really challenging moments though, and even though he's been on medications and well medicated and stable for quite some time, we still have challenging times in spite of all that. And I've really enjoyed being part of the Psychosis REACH program and learning about the first skills, because it continues to be a very helpful model for our family in terms of how to sort of navigate the waters that we find ourselves in when they get rough, and how to keep things calm and keep us from going under. So the first skills include 5 different things, and this summer we had a unique opportunity to put them into practice. We moved a year ago, and our son moved up with us to the area of Sequim just a couple months ago. And that was a huge change for him. And not only did he move to a whole new house with us, he left behind friends and family who he's very close to and found very supportive. And he also left a job he'd had for a year, and he was starting a brand new job up here with all new people without the support of his job coach. So it was a really stressful time for a few weeks, and he started feeling excessively fast heart rate. And as a result of that, he had some delusions about why his heart was racing so fast. And they had to do with people doing things to his brain and causing his dopamine levels to change. And he was very anxious and very frustrated. And the first skills allowed me to fall back on some things that we've already established. The first one is to form a relationship. That's the first piece of the first skill, the first F. And we have always worked hard to have lots of conversations with John about all sorts of things that have nothing to do with his diagnosis. And so having that relationship with him, he's willing to talk with us. He wants to talk about his experiences. And as part of that forming the relationship, one of the things that I learned in the first skills is how important it is to normalize the kinds of things he's experiencing. And having a rapid heart rate is something I too have experienced when I get anxious or upset or angry, or, you know, all different kinds of things can be reasons for that heart rate. So we had some good conversations where I just listened to him and did the second part of the first skills, which was to inquire curiously, the I. And I basically just asked him to tell me about what's happening. What's up? What are you noticing? What are you feeling? What are you thinking? And we collected data about what was going on with him. The third thing we did is to review and put that information together in some way, to look at what his thoughts were, what his feelings were, what his behaviors were in response to this rapid heart rate. And so we were able to identify that he felt very scared, he felt nervous, he felt anxious, he was worried. And we were able to talk about, so what kinds of behaviors, what are you doing? And talk about the coping strategies that would work well for him and which things wouldn't work so well. We were able to determine that what he really wanted to do was seek some help, because although he had some delusions about why he was having this rapid heart rate, he felt that it would be important to see a doctor because he thought he was going to die. He thought he was going to have heart failure. And so we made a plan for that. But the next thing we did was to try and think of, so until we can get to the doctor, what are some other coping strategies you can use? And that's where the fourth step of the first skills came in, called skill building, the S. And I love the book that we were recommended, Back to Life, Back to Normality. It's become a little Bible for us because it has lots of different strategies in it that we could use to help at times like this. And so some of the kinds of coping strategies that we did use in this particular experience were having him remember times when he's been really stressed and when he coped effectively when others were very kind to him and responded really well. So we spent time thinking about that and that it was a positive experience. Also about what he might say to others if they were in the same experience. What were the kinds of things he would like to hear? What would he say to someone else to, again, normalize this for him? And then simple things like perhaps the smelling of lavender would be calming for him. And because we're in SQUIM and lavender is a big thing, it's real easily accessible, something we could use. And talking about smooth rhythmic breathing as a way of dealing with anxiety in the moment. So the last part of the first skills is to try it out, the T. And so we made a plan for how we were going to do this together, my husband, my son, and I. And we actually went all the way into Seattle to see the ER there. We talked about why that might be a more effective coping strategy for him because his psychiatrist is in Seattle. And it turned out really well. So I thank the Psychosis REACH program for giving me such a nice model of a way I can think about how my son and I can deal with things when times get stressful. Thank you.
I know we're running low on time.
Hi, my name is.
No, we're running low on time, so I want to share with you how we deliver Psychosis REACH intervention and how that can help the clinical care team and family members, and then talk about where you can access the training. So we really center family members. Like I said, families were critical in the development and kind of iterative development process of this training program. So we want to make sure that we're helping them kind of make the links, make the connections to the intervention. We offer a self-paced e-learning where they can kind of go at their own pace. It's 5 hours in total. We give them 3 months to complete the e-learning course, at which point they'll have a live skills workshop where they'll have an opportunity to actually see the skills that we're teaching them in action with an actual family member who used these skills in their own life and is role playing their loved one. And our clinician, these are top experts, the most renowned experts in the treatment of psychosis using cognitive behavioral therapy in the world. So it's a really nice opportunity to see how a CBT for psychosis expert would use these skills in the role of a family member. Then we connect them with a trained Psychosis REACH family ambassador like Trez, who's undergone an additional year-long intensive training program to work with family members to learn these skills. And they have access to an online community board so that we can start to cultivate a family network where folks can be less isolated and more connected to other folks. So you can see how the training model really lends itself to learning from clinical experts, learning from experts by experience, and really getting access regardless of where they are in the world. If you have an internet connection, you can access the intervention. And it's not intended to supplant family intervention delivered by an ACT team, an outpatient team, an inpatient team. It's intended to augment. So we really see this as layering on what the clinical team is doing so that hopefully they can work together. And because of that, we offer about up to 20% of our training cohorts we will reserve for mental health clinicians so that they can also get exposed to the intervention that their families are getting exposed to. And then I mentioned Psychosis REACH family ambassadors. I really just want to kind of say what they do. This is really based on the peer model, the peer specialist model, and the research that's coming out of the value of being able to connect with somebody who has comparable lived experience. What we do with folks who have been through our core Psychosis REACH training program and have the capacity and interest in working with other family members is we will give them a 12-month-long course and a manual on how to work with other family members, how to connect with them, how to hold the hope for those families, how to help them learn these skills and make them their own, and how to advance a recovery agenda and reduce psychosis-related stigma. So last bit here is just to talk about the dissemination model. We offer different ways that folks, different regions of the country can start to bring Psychosis REACH to your family members. One is a Psychosis REACH core training, and this again gives access to the entire training model, which includes the online self-paced e-course, the discussion board, resources, and the 3-hour live workshop. At that point, we do also give them the contact information for all of our trained Psychosis REACH family ambassadors. Some of them may be operating on wait lists, and so they might need to kind of shop around a little bit or be persistent. The second level of training is where we'll do that core training for a specific region. And then in addition, we'll do the family ambassador training so that we can start to develop that cohort of family ambassadors in a region. So that would be the 12-month training program, and that includes access to that training program for up to 12 individuals. And that training program also includes a mixture of self-paced and live synchronous training. And that's directed by Dr. Akantra Baswani Bai on our team here at UW. And then the Psychosis REACH Train the Trainer model offers everything that I just talked about. And then in addition, we would do a Train the Trainer where we're teaching the Psychosis REACH family ambassadors, as well as a clinician trainer on the team to be able to do Psychosis REACH trainings in that region in the same way that we're doing here at the University of Washington. And those training packages require a licensing agreement. They're all sort of information about those are available on the Psychosis REACH website, which is psychosisreach.org, or you can reach out to us at psychosisreach@uw.edu. So I hope I'm still on time here. I'm going to stop sharing with Maria, see how we're doing.
No, you're doing great. Thanks, Sarah. Let's see, we had a question in the Q&A, but I think before we get to it, I was curious, Sarah, if you could kind of share a little bit more about, so, given how, most folks on here are working with ACT teams, how would you sort of see them what would be the next steps in terms of being able to kind of use Psychosis REACH? And how, you mentioned kind of the training, but just really being explicit about kind of like what's for them and then what's for the families that they work for or work with, I should say.
Ideally, let's go with the ideal, and then I'll sort of say what might be like a realistic next step. Ideally, I would love to see a world in which CBT for psychosis therapy and family interventions are delivered on every ACT team, and ideally a CBT-based family intervention for psychosis. That's best practice. Realistically, it's very difficult to access CBT for psychosis training. It's very difficult to have the time to deliver the intervention. CBTP, we don't even really fully understand the kinds of adaptations that are indicated for this intervention. There's very little research on that area. And so what does this look like when you're meeting folks, at a McDonald's? What does this look like when, you can't get somebody to meet with you once a week for 50 minutes? So I recognize that we're pretty far from the ideal here. What I would love to see sort of in a more realistic way is to go onto the website to see when you can join a cohort, right? We operate a minimum of 4 cohorts per year. So it's on a quarterly basis. Our current cohort, which launches with their live training in March, is now closed. After that March 10th training, we'll open up the next training. And if you can get into one of those, then you can start to see what are the family members being exposed to, and how can I kind of start to use this language in my practice if I'm not already, and then how can I start to identify which of the ACT clients have natural support, who are the natural support, how often are we engaging them? How can we start to engage them more? And then at a minimum, can we let those natural supports know about Psychosis REACH so that they can pursue it independently? And by the way, I should also say Psychosis REACH is not the only intervention that family members can do independent of the clinical team, right? So the LEAP Institute offers, this is Javier Amador's intervention, motivational interviewing-based intervention for family members. They offer trainings directly to family members. NAMI, of course, does as well. They have their family to family. So, I think pragmatically right now, every ACT provider can cultivate resources, curate resources, I should say, and share those with family members so that they can pursue independent training when possible.
Thanks, Sarah. I know one of the challenges, I think, on ACT is that in most places, they don't have a family specialist within the team, someone who's kind of designated. And so, I think we encourage folks to then sort of look within your team. Is there someone who's naturally, either they're training, maybe they're a master's level clinician in your team, or somebody who's got a lot of interest in working with families to kind of take the lead? Obviously, multiple team members work with families and that won't change. But I think in terms of kind of leveraging some of this expertise and thinking about kind of who on the team is sort of spearheading the implementation of something like Psychosis REACH and other family interventions, that somebody on the team kind of be designated to, take that course as you have that 3%, of clinicians who can take a course when they're open, that kind of thing. So that's the goal there, I think, and just kind of figuring out within your team who would be the one to do that. We've got some questions. One has to do with strategies, given kind of what you described within Psychosis REACH of shared understanding and those kinds of things. What if the family member and their loved one have strong differences in beliefs from one another? So, for example, the client identifies as LGBTQ+ with a parent who wants to take an approach that is not queer inclusive.
Great question. Diving into some really, really challenging topic areas. This is a great question that reminds me a lot of a question that I received. I think it was our first Psychosis REACH training, where a family said, "Is it possible that a family and their loved one are so estranged and so like on opposite ends of kind of perspective that you just can't repair it? You can't repair the relationship." And the optimist in me wanted to say no, but the realist in me wanted to say yes, that is possible, right? And I think certainly where you have sort of these abuse histories of abuse, whether that's emotional abuse or physical abuse, but we have trauma within the family. I think it's very, very difficult for us as care teams to repair that kind of longstanding those kinds of longstanding dynamics, or issues of mistrust, or issues of just not being seen in the way that person deserves to be seen. And so I think we have to also recognize our own limitations as care providers and what is within our own control. What we can do is we can offer our perspective about what the evidence would it would suggest is indicated, and that includes research on acceptance of an individual who identifies as LGBTQIA or gender nonconforming. And I think that's what we can do. And if the family member is not accepting, then we work with the patient. We always work with the patient as care teams. They're our number one, they're our client, about how to form healthy relationships with people who will affirm their personhood.
Got some other questions, Sarah, about are these trainings open to all, regardless of location? And I know you spoke to that a little bit. I just also put the kind of list of the trainings, the upcoming trainings coming up for the free course, because there was another question about physical commitment to engage in this. Can you kind of clarify those?
Sure. Yep. So we do, at this point, we have an open model. So we cap our registration in each cohort at 100 participants, of which about 20 will be clinicians and the remaining spots go to family members. We have hit that registration cap, within days of opening each registration cycle. And so while it is open to anybody across the country, it can be difficult to get in. And so that's why we developed the dissemination plan, where we will either do a Psychosis REACH training just for folks in your region, up to 100 folks just in your region, or you can actually become a Psychosis REACH training hub if a state has capacity for that, or an academic institution has capacity for that, or training center. And so those are different levels of commitment and financial commitment for those. So again, kind of reach out to us so you can find out what's right for you, and we can kind of take the conversation from there.
Great. Other questions from folks? Feel free to raise your hand, and we can unmute you and you can ask it directly, or you can put it into the Q&A box. I thought this was an important topic for ACT in particular, just given, we often run into a situation where, a lot of the folks that we work with are not in touch with their families, or it's a very challenging situation or relationship with their families. And so, really ensuring kind of that the team has skills on board that are not unlike the same skills as you said, Sarah, with, more kind of using a CBT-informed care approach to working with families as well as working with individuals on the team. Any other questions? Okay, we got a hand up. I will allow you, Dartis, to talk here. Feel free to unmute yourself now.
Good afternoon. I have a case that this child is 17 years old and has been gone through psychosis, been in the hospital, is back home. And he doesn't want medication. That's out of it completely. He has gotten medicine. He has gotten like Invega, and he will never take any more medicine. That's his thing. So we're struggling with mom at this time and the child, who will not respond verbally to us, just shrugging the shoulders and just answer when he wants to. So I'm trying to figure out the fact that he's not going to take any form of medication. He's not responding. I just input on what else could I do? I mean, I'm the practitioner, so medication management, but I'm really concerned because I really need him to get the help that he needs, but he's not responding. He responds when he wants to. And, medication is off the table apart from, some omega-3 and St. John wort that I said we could try. But I feel like he's way past that and he needs medicine, but it's off the table for right now. So what else? Is there anything that you think, any approach? What could I do? I don't know. I'm kind of at a crossroad at this point.
Yeah, I think this is difficult for all of us as care providers to know that, kind of gold standard is that we have medication to help with the acute psychosis, and that we're kind of complementing that with our other approaches, including CBT and working with the family and peer support, et cetera. One thing I would say is sort of understanding what's happening with the non-responses, and whether this is negative symptoms, whether this is mistrust. I think really kind of being curious about the client's reasons for not wanting to take medications. One of the tools that I wish I could teach every single practitioner in the world really is the payoff matrix or decisional balance, which really addresses the question of why are we seeing what we're seeing, whether that's a behavior pattern or whether that's a thinking pattern. What is the function of it? And the payoff matrix helps you understand from the client's perspective, what are the advantages of staying exactly the same? In this case, not taking the medication. What are the disadvantages of that? what are the disadvantages of changing that behavior? For instance, starting to take something to help with the psychosis or sleep or whatever he identifies as a problem, versus the advantages of making that change. And not only is it helpful because it facilitates change talk in the client, which is primarily the intention of that motivational interviewing strategy, but it also helps us as providers to understand what is keeping this person stuck there, right? Why are they so firm in this pattern that we're seeing? And when we understand that, we can kind of get insight into, oh, is this a misunderstanding that they have, a misconception, a delusion? Is something being reinforced that we weren't even aware of? In which case we could change the way, what we're reinforcing, what's being reinforced. It just gives us so many avenues to collaborate with the client, to understand things from their perspective, and to look for ways that we can promote some change.
Good question. Thank you.
You're welcome.
And also, Sarah, the question had come up about clinicians. Are you wanting to keep it to master's level clinicians or bachelor's level clinicians? What is the requirement?
Open to all. Open to all. We really want to make sure that and the intervention is designed to really be all inclusive.
Mm-hmm. Which is why we're kind of calling it more CBT-informed care versus that they're doing CBT. And many of the family members learning it too are they don't necessarily have a master's degree or maybe not even a bachelor's degree or
right.
So
absolutely right. If we're really going to be creating a mental health service corps where everybody can be speaking the same language, then we have to make sure that you don't need a degree to speak this language.
Exactly. Great. Well, I think we've got all of our questions in the queue that we have answered, and we really appreciate you taking the time, Sarah, to share more about Psychosis REACH with us. I know you're going to be coming back in June, I believe, to share more about how ACT teams can use CBT for psychosis kind of within the work that they're doing on the teams too. So this is a nice little kind of first step into talking more about that as you come back in June. So thank you again.
Absolutely. I'm looking forward to that. Thank you all for having me. Thank you all for the work that you do.
Thanks, Sarah.
Take care.
All right. Well, this was helpful. I think as we all have probably observed at times, this is an area of work within ACT that could often benefit from some improvement. That I think on average, we see teams reporting that they have any contact with natural supports with only about a quarter of the people they're serving. So kind of the reach and access to natural supports is one thing. And we often say if it's because, quote unquote, they don't have anybody, that may give reason to try to work on that, because most people want somebody in their life, or it may be they have people in their life, they just have reason not to trust us to have access to them too. So that's a whole nother issue. So, but then when you do have access, what are you doing? And sometimes what we hear from teams is that they're responsive to when family members reach out to them out of concern, or they access family members in very instrumental ways, like trying to track somebody down, but don't necessarily go in and approach the natural support as a means of intervention in support of the people that the ACT team is serving. So I think this gives another nice, like very practical set of tools of what we would be doing when we're reaching out to work with mom.
And I'm about to put an example of a decisional balance if you haven't seen it. Sarah used kind of two different terms there, either payoff matrix or a decisional balance. but they're essentially the same thing. Pat Deegan has one in particular that I really like because it allows people not just to put whether, pros and cons for why, to make a decision to do or not to do something in particular, but also it helps to rate each one. So which of the pros and cons have more weight. Mm-hmm. And then it has ones that allow you to do the decisional balance along with a family member or natural support. And that way you can kind of compare and contrast kind of where you're at compared to your loved one, which I think is really nice. And the more standard ones that are out there don't give you kind of that level of nuance. So I think it's particularly helpful here with Psychosis REACH. So put it in the chat.
So as we're transitioning here into kind of open mic time, where we create space for you all to just pitch questions to each other and us across any topic, we did want to do another just quick plug on a national survey that we've been conducting that is going to close tonight. Thank you all, because I know there's people on here that have taken the time to complete it. I do believe it takes about 15-20 minutes to complete. But as part of our national study of ACT, which we're wrapping up this year, feels like it's been going on forever because it has, but we have collected an enormous amount of information. But you all, team leaders and program managers, are an important source. So let me see. I'm going to put the link to the team leader survey in the chat. In it, you will see information about informed consent and also a raffle that you would be entered into. And just a specific plug, we have any guesses of how many responses we've received across the nation? So this has been live now for about 3 weeks. And how many do you think we got? We're very excited. Higher, Katie, higher, aim higher. Lena, you're on it. Oh, Alicia, I would love that. All right, I got us too disappointed with all this excitement. We have 383 responses so far, which is a really nice response rate to be targeting team leaders and program managers in particular. So this is going to give us such important information. And one of the things that we've been trying to do is trying to get representation across all the states, because if we just get, say, only 10% of a state responding, we don't know if we're getting the most excited and invested team leaders. Are we getting, the most disgruntled and want to express what's going on? So it's nice to have some representation. And this data, just as a reminder, how it's going to be used is we're going to look at national trends and report out descriptively what we're seeing from all of you. But also, for the ones where we hit our representation mark, which we're looking for at least 20% of teams to respond in an area, then we can integrate your responses in with other data that we've been collecting from talking to your state mental health providers. If you have a local TA center, we've reached out to talk to them. We've even surveyed 1 or 2 of the providers too through another survey method. So we'll be able to create a profile of what's going on that's more accurate when we get your represented voice as part of this study. So I'm just going to particularly put a shout out. If there's anyone on here from the great state of Nebraska, we would love you to complete this survey because we haven't hit a representation yet for you all. We think we've reached it for Colorado, but if there's any Colorado teams who haven't taken it, we'd love for you to join in. Also for our friends in Nevada, if you're on here and haven't completed it, it would be awesome. Possibly Texas. We're still trying to figure out how many Texas teams there are, but we have 5 so far, which we really appreciate. And another plug for West Virginia. It has not circulated at all in West Virginia. So if we have been able to get some from you all, that would be fantastic. So it's going to close tonight, and we can't wait to get these results back to you all. It asks things like, who you're serving, has who you serve changed? Have you struggled with staffing turnover? And it's all closed-ended questions, so usually you can click through it pretty quickly too. Yes, and thank you. Somebody just pointed out, as much as we test out these surveys, something will get biased that frustrates the crap out of me. One of them is what you're pointing out, Adina, that there's a question that asks about which crisis alternative service do you have in your area? And it doesn't give you a chance to say none of these. So you have to pick one of them to move on. And why it was set up that way is because it's trying to set up for the next question that then asks for, although you have the service, do you find that it's accessible for the people you're serving? So I know I have a way in which we can handle the data to use what we think is most valid, but it's a frustrating flaw we noticed.
And again, I mean, you guys, some of you heard Lorna's presentation back in August, I believe it was, with some of our initial results from this National ACT study. So more talking to kind of states and, folks in the state that are really supporting ACT at the, state and, community level, regional level. So, we'll come back and we'll share more, I think, of the results, not just of the larger study, but also, as Lorna said, just of the results of the team leader survey too. We just really want to get a sense of kind of what's going on out there. And we know a lot has happened, especially with, COVID and the impact of, the last 2.5 years. I think I've said 2.5 years for probably too long. It's probably more like
I know
at this point. So great. Well, one thing we did want to ask you all about has to do with the next presentation as well. So, I mentioned that Pat Deegan is going to be coming in to chat with us about the role of peers in kind of talking about or managing medications. And in some states, we are aware that within the certified peer counselor training curriculum, it's been sort of prohibited for peers to have anything to do with medications. And it's often kind of a pretty common approach. And yet within ACT, we know that we have kind of a mix of like some of these teams where your peer specialists are, out there doing medication management or, talking about their own experience with medications. I think what Pat is wanting to do is kind of use this as an opportunity to have some guidance or parameters around which those conversations can be had with the peer, because she really views the peer as a really integral part of the team to really be able to kind of leverage their expertise and their experience as someone having been on medications themselves to really be able to have some of those conversations, but also providing some guidance or a framework on how you make those decisions as a peer. So long-winded way of, or long-winded sort of entree into my question. So I'm just curious, you can put it into the chat. What is your state's, and you may not know this, but if you do, what is your state's view on peers being able to discuss medications? Oh, and that's a good question, Katie. Can we also discuss how to better recruit peers onto an ACT team? I think it's going to be probably outside of her scope because she's going to be so focused on this particular topic, but I think it is definitely one that we're feeling, and we'll probably be bringing into one of these the two-part series or calls that focus on kind of the workforce shortage. So stay tuned on that, Katie. We'll let you know when that one's available. So let's see, Tammy says you can administer trained in med management. What about other states? And maybe say where you are too, if you're feeling comfortable with that, which state. We just want to get a feel for kind of what Pat will be coming into in terms of states' understanding of whether peers should be doing anything with medications. Is that all we got? Certainly we have more people. Okay, Oregon's peers cannot do med management. Okay. No limitations in Virginia, Maine, no. So the question again is, in your state, are you aware of the parameters of the peers role and whether your state actually does not allow peers to either talk about medications or handle medications, like through like a med pass or a med monitoring kind of approach, medication delivery? Okay. So we're maybe so far 75-25. No, but we're starting to get a few yeses. In Colorado, if they are a QMAP, so they can be a QMAP as a peer, and then they can. Okay. Okay. All right. Well, that's helpful just to kind of get a sense of, I mean, if we were seeing overwhelming one or the other, I think, but that's about, I think what we thought is that it's kind of mixed, you know, so, and all the more reason that we have Pat come talk to you all, because if peers are going to be playing an integral role within the team, what is that role? What does that look like? And I think there's a lot of confusion about that. Pat has talked about the role of peers in a clinical team, including within ACT teams, and I can put a link to that particular webinar series here in a minute. But I think this is kind of the first one that she's done that really talks about sort of the role within medication discussions and medication delivery or management. So stay tuned for that. I'll put that in the chat right now.
Yeah, so while Marie is doing that, this is your time. Any topics open, put out there, either in chat, the question box, or come on the mic with your hand up.
It's a quiet room today.
Well, I'm so glad you guys are doing so great out there. Katie has a question.
Do you want us to unmute you, Katie?
Yeah, let me see.
You want me to do it?
Sure. I agree. The risk of peer drift, I see, Lena, and also the risk that there's some teams that never knew how to utilize the peer in their role from the beginning too.
Can I talk?
Yes, we can hear you.
Sorry, I'm on my phone and I'm having trouble texting. I'm curious from states that are not in Maryland. I tried to ask this on the listserv and I don't know if I posted it right, but I'm curious what other states do for compensation for staff who are on call, and then also for team leaders who are on call for more than one team at a time on the weekends.
Good question.
Can I just quickly ask the person who raised their hand if they're going to be answering Katie's question or not?
So how are you all compensating for staff that are on call? And then further, is there any additional compensation given to team leaders, particularly when they are providing support to more than their own team? Okay, we got one response there, $135 a week for on-call, but that's too low. I'm sorry. I have bad dashboard arrangement right now. I gotta try to see my chat better. Varies by organization. Team leads do not get any extra compensation. The staff that is actually on call gets a flat reimbursement rate per on-call day and extra on holidays. So that's another response. Okay, and I see your other question there, Kelly. 75 for the weeknight, 100 for a weekend day.
through some of the people who are have their hands raised. Patricia, do you want to?
Yes, ma'am. Hi.
Yeah.
I'd like to go back to that peer drift. I missed it. Unfortunately, I've been having to come in and out. I missed it. What is that? What's a peer drift? What is that?
We were referring to, Lena had mentioned about the concern of peers drifting in their respective role. So they may come on with some clarity of what their job responsibility is as a peer, but then you start having things happen like workforce starts turning over and you need some extra hands to pitch in to take people to the grocery store and deliver medications. And it might start compromising what the intention was of the peer role. So they start drifting away from what their core responsibilities were intended to be. And then I was commenting that some teams never even implement from the beginning the peer in the role as intended. And this happens a lot with the peer, but quite honestly, it happens with nearly all team members on an ACT team, the extent to which they get used within their intended specialty areas.
Yeah.
Oh, sorry. Maria did a neck yank on you by accident.
It's all my bad. I'll try to get you back up.
All right. Jennifer, should we?
Hi. Yes,
Hi.
Jennifer Chan. I'm the program manager at Marion County Adult Behavioral Health in Oregon. And I can comment on both things. I've seen the peer drift when I was the clinical supervisor of ACT. They had the peer doing things like just transporting people or check-ins, dropping things off. A little bit of case management and skills training. So I worked really hard with the entire team. And I've seen this with other teams as well, where the roles really blend together and everyone just does anything as it comes up. And so we had to work really hard to get everyone to work within the top of their role while still having every ACT member being an equal member of the team. Just in different specialties is the way I framed it. And since then, we've had the peer support specialist engage. He does just amazing work working with our individuals within their peer role. And I think once the team really understood what a peer support specialist role is, what they do, and how much power they truly have to make a difference, to engage people, to talk to individuals and use their lived experience, to talk about, here was my experience off meds and on meds, and give people things to think about. I think once they started seeing the results, the rest of the team was able to help support the peer to work within his role instead of just doing things as they came up.
Yeah.
So that it took some time, probably I'd say a year. So
yeah, thanks for sharing. I think that's really, we've been working with somebody here in North Carolina who's developed a training around how to supervise and support peers, because a lot of times we don't have within the agency other people higher up in the organization that also has been trained and operated as a peer and can provide that kind of support. Because as you shared, there's a balance of how to connect with people around lived experience without imposing what worked for you and what didn't work, and trying to navigate that space well.
Yeah. And we even have a peer support specialist clinical supervisor.
Oh, that's great.
Yeah. And even with that, we still had trouble. So one of the things that we did was we had our peer support specialist and that clinical supervisor create a training, like an orientation for new staff when they come onto the ACT team of, this is what a peer support is. This is what the peer support does on an ACT team. This is what they don't do. This is the power of a peer. And that's helped when new staff come in to just start from ground zero. It's a fresh perspective. And so we just train them into that mentality of keeping our peer support within his role.
Yeah. Great. Thank you for sharing.
I think that, can you hear me?
Yeah.
Yeah, thank you for sharing that. You're right. As far as a peer support specialist and the role they play, I'm glad that you're going to be doing a training on that, because there's a lot of times where the rest of the staff or what have you don't really understand the role of peer support. And I think it's good to we're ACT. Okay, so like that other lady was saying, we get involved wherever we're needed, and we go here, there, but peer support is a fundamental part of the care team, and there's many times where a patient won't open up to the therapist, let's say, or to a case manager as like they would to a peer support, somebody that has a lived experience, somebody that's, been there and gone through what, let's say, what they're going through. And, so it's interesting, it is. And it's good that, peer supports, in my opinion, is they're a fundamental part of the team.
Absolutely. And I like, we see and hear a lot about just appreciating the peers' ability to join and establish a space with more trust, sometimes at a better rate than other team members. And we also like to point out, why is that? What they're doing sometimes is something we all could be doing, listening more, humility, compassion. As Dr. Kopelovich said earlier, genuine curiosity about why people are choosing the choices they're making, instead of where we come from sometimes when we're not necessarily coming from a peer perspective per se, is we sometimes lead with the foot of risk management. How do we manage the risk in front of us? Whereas peers who are really well trained understand how to sit with distress in a way that sometimes we don't do a great job with. All right. Anyone else?
Jennifer, I saw your hand back up. Do you have a comment or question? I want to make sure we capture it.
It wasn't back up. It just a thing popped up for me if I wanted to unmute.
Okay. All right. No problem. I'll put you back in. Thank you.
Okay.
Yeah, so a great discussion. I put the other two webinars in there that Pat Deegan covered. And again, it's not specific to ACT, but I think she really does cover ACT when she talks about the role of peers and clinical teams, because kind of the premises that you're kind of also working with psychiatry and nurses and, kind of more of a medical team. And so the role can feel kind of like it can become much more clinical, or like they're a junior clinician. And so she, talks a little bit about sort of what are those parameters that she recommends for peers with working within clinical teams. And then the other piece, which I think I heard on this call as well, is just how is it, what do you need to do, or what do you need to know to supervise peers? And so I think that's a good one for our team leaders too, to know kind of some of the ins and outs of that if you haven't gotten something like that already. Somebody also asked about if we can share some of the responses, especially around the on-call information with others. And I think we can do that. We can just kind of put it into an email to participants on the national call. I'm trying to think, do we ask anything like that in our survey? No, we don't. Yeah. This is great information. Thank you.
And I saw yes, we know that peers in particular are often underpaid, but many team members on an ACT team are underpaid in many states, but peers, because of the fact that they may have lower qualifications in terms of education, and so much gets built around education when they do rate setting, unfortunately. I'm hopeful that as we continue to shift towards value-based care payments, that we truly actually reimburse and pay for people because they bring true value that then yields the outcomes that we actually are wanting out of everything, for the services, helping people get jobs, helping people succeed in the type of housing that they want, that will elevate. But yes, We understand they're underpaid.
Maybe time for one last question. Anyone has it? We've got about 4 minutes before we need to sign off. Lots of good responses. I'm going to put our evaluation link in the chat. Again, we love to get feedback, to be able to kind of know, sort of how do we drive kind of our ongoing meetings like this and any topics. So I'm going to do that now. I think we have surpassed the number of folks asking questions. So we hope that you all will join us again in April. So we'll again not have a meeting in March, and then we'll all get together again on April 3rd. And we'd encourage, anyone who is particularly your peers, but also just thinking about kind of anyone who is interested in that role. Hopefully the whole team is, but just making sure that you all know that we're going to focus primarily on that peer role in the next one. And I think I'd really encourage a lot of our team leaders to also be participating in that one too, wherever you can. We'll follow up with some of the answers in the chat after today, so that you have some of those. It's good for us to kind of catalog some of the responses in there, since we often don't have other ways that we capture that kind of information. So thank you for putting that in the chat as well. And you all have a great rest of your winter. And then when we all get back together again, it will be spring. It's hard to believe. So
yeah. You know why they're so quiet? Because I just had 20 responses to the survey come in. So you guys rock.
Really? Oh my God.
They all just started popping up. So thank you. And to my Indiana person, you just doubled your number there in the state.
Thank you.
Thank you.
Thanks, everyone.
All right.
April. All right. Bye.
Bye.